This is the lung assessment continued. We're going to move on with good chest movement for the posterior aspect of his back. Spine is midline. There's no obvious noted abnormalities, no kyphosis, lordosis, or any leaning to one specific side. Patient exhibits good posture. He's able to sit up well and tolerate appropriate posture. There's no mechanical reason why he can't have symmetrical breathing. He's able to compensate well. For example, if a patient is elderly and hunched over, or arthritis, they may not be able to expand their chest adequately based on other complications. We're going to assess good chest movements, diaphragmatic breathing, thoracic expansion. I'm going to put my thumbs at the 10th rib and evaluate for good symmetrical expansion of his chest. Go ahead and take a nice deep breath. Good. Good expansion of the chest. It was symmetrical on both sides. We're going to evaluate for tactile fremitus and make sure there's good palpable vibrations throughout his chest. I'm going to have the patient recite the words 99.
99. 99.
Good. Palpated vibrations throughout. Good vibrations. Good. No masses to the posterior aspect. Next, we're going to move on to auscultation. We're going to auscultate the posterior lungs. We're going to go from one side to the other, evaluate and compare one side to the other. We're not going to go down one side at a time. You need to compare both sides equally and make sure you get the lateral aspect of the right, especially to evaluate the extra lobe on the right compared to the left. And then we're going to move to the front and listen to the front of the lungs and also the upper airways and make sure there's no wheezing, stride, or any other abnormal lung sounds. We have to do percussion. We're also going to do percussion as well, and auscultation and measurement of the chest, measurement of the diaphragmatic excursion. We're going to palpate and make sure there's resonance and dullness where there should and shouldn't be. Okay, good. Next, we're going to evaluate diaphragmatic excursion. I'm going to have the patient take a nice deep breath in and hold his breath. All right, and breathe out. And take a nice deep breath in again and hold your breath. Okay, breathe out. All right, take a nice deep breath in and exhale and hold your breath. One more time, breathe in and breathe out and hold your breath. And we're going to measure that, make sure it's between 3 to 5. Good. All right, and we're going to move on to the auscultation. We're going to do the front. We did do the Posterior. All right, we're going to take a listen to the upper airways. Nice deep breath. Good. Lung sounds are clear. No adventitious breath sounds, no crackles, rhonchi, wheezes, friction rub, no noted obvious hacking cough or barking cough. Good tracheal bronchial breath sounds, no abnormal stridor or wheezes in the upper airway. Can you just take a, can you cough for me? Good. Patient has good ability to clear his airway and maintain his airway if needed. No obvious noted nasal drainage or any obstruction or any growth to a space that would warrant for any possible obstruction or inhibit his breathing. Overall, pretty benign respiratory chest and lung assessment. Do you have any questions or concerns?
No.
All right, thank you very much.